Good morning. Welcome back. Today we're going to talk about cardiac masses, and since we have a lot to cover, I'm going to go right to it and get started. So this is an algorithm that I think a radiologist should use whenever we're faced with the clinical question of a cardiac mass. The first thing that a radiologist should look at and think about is whether the thing that somebody saw on some other imaging, like for example, on echocardiography, is that really a mass? Because all too often, it's actually a normal structure or a normal variant or variant anatomy, and it's not an actual cardiac mass. And that's very important for the radiologist to notice and let the clinicians know. And we will look at quite a few examples for that. The next thing a radiologist should think about, the most common cardiac mass is a thrombus or a clot. We will talk about that extensively as well. But the most common abnormal tissue that you will find in any chamber of the heart is going to be clotted blood. And there's always a reason for that. We'll talk about all the reasons. The next most common thing is going to be some sort of actual growth, but it's not coming from the heart. It's secondary. Therefore, it's a metastasis. And the next most common, and you see how unlikely these things are, is going to be a neoplasm that's growing from the heart, but it's benign. Therefore, it's not as big a worry, but if it's on the left side, it probably needs surgery. And the next most common thing will be something malignant. So this is going to be our roadmap for this lecture, and we might have to break it up into two pieces because I want to go through a lot of cases and want you to remember this algorithm in your head whenever you're faced with a cardiac mass. We'll recap this at the very end. So what are these findings that are not actual masses, but the patient is coming to us with the question mark mass clinical question? The crista terminalis is in the back of the right atrium vertically, sort of connecting the IVC and the SVC, or those ostia. The eustachian valve is at the entrance of the IVC, at the inferior aspect of the right atrium. Lipomatous hypertrophy of the interatrial septum is something that we see in our society quite a lot. It has to do with patients who have a lot of visceral fat. By the way, those patients will also have quite a lot of fat in their crista terminalis, like really almost mass-like. We will look at pictures, of course. The Coumadin ridge, which is between the left atrial appendage and the left superior pulmonary vein, is a structure that can be mistaken for a thrombus. The aortic root, in some patients, it's prominent and protrudes into our dedicated cardiac views, specifically the four-chamber view, and can actually be mistaken for a mass. I've seen that several times. You can have an elevated hemidiaphragm with the liver kind of pressing on one of the chambers, giving the appearance on echocardiography that it is an actual mass. Additional things that are abnormal that could be misconstrued for sort of cardiac masses, these are cardiac or paracardiac masses, like a hematoma in the pericardium, a coronary artery bypass graft aneurysm, vegetations on the valves. Those are actually like intracardiac masses, of course. You can have papillary muscles that rupture, that look very mass-like, but are normal parts of the cardiac anatomy. And the epicardial fat can be very, very prominent and very, very scary on echocardiography. So sometimes you will get referral from cardiology for somebody who's got pericardial masses or epicardial masses. And all that's happening is the patient has kind of irregular shaped epicardial fat with a little bit of pericardial effusion that makes it look funny. So let's review a couple of these cases. The crista terminalis is in the posterior aspect of the right atrium. This particular patient also has fat in the interatrial septum. So you have lipomatous hypertrophy of the interatrial septum with sparing of the fossa ovalis. This is the normal, usual appearance. Notice that patients like this also often have lots of epicardial and pericardial and mediastinal fat. They might have a lot of visceral fat in the abdomen. The peculiar thing to notice here is this black outline, both around the crista terminalis and the lipomatous portions of the interatrial septum. And that has to do with the fact that we're using a steady-state free precession sequence where at all fat-water interfaces, you will get this black outline. So that's not something very specific to the fat itself in this region, but it's just a fact that fat and water are meeting, water being in the wall of the atrium and in the blood chamber, and fat within this lipomatous portion. CT appearance, just an unusual appearance, that usually not the way people look at it, but on coronal view, the crista terminalis, when it's filled with fat, looks like this. And of course, on axial view, you will see that it can be very, very prominent. It can have sort of this intermediate density because it has some fibroconnective tissue in it. And of course, the wall of the right atrium is a little bit muscular as well, intermixed with some fat. Notice also that the lipomatous hypertrophy of the interatrial septum here is a little bit higher density than pericardial or subcutaneous fat. And that can happen sometimes when brown fat is present within the lipomatous hypertrophy of the interatrial septum. So these are just two different pictures, one with and one without contrast. It's very important to not call an ASD in these patients because it's very tempting, especially without contrast. It looks like there's a big hole in the middle of the interatrial septum in patients with lipomatous hypertrophy, but most of the time that's not the case. It's just sparing of the fossa ovalis. Just more variations on the same theme. Very fatty crista terminalis, very fatty interatrial septum. And you can notice here on this cine CT image that this can actually look like a mass adherent to the wall of the atrium. And for us radiologists, it's very important to identify this as just a normal structure. This patient has a prominent Coumadin ridge, which lives in the superior aspect of the left atrium. This is our left atrial appendage with the Coumadin ridge here next to the origin of the left superior pulmonary vein. This is called Coumadin ridge because Coumadin is an anticoagulant, and a lot of patients in the olden days would get on anticoagulation because the cardiologist thought that they had a left atrial thrombus. Here's another view slightly higher up of the Coumadin ridge, not to be mistaken for a mass. In the same patient who happens to be a child, we have the eustachian valve very prominent as well. Here at inferiorly in the right atrium where the IVC is joining the right atrium. So that can be very prominent, especially in children. This is a 1-year-old child. You can see the aneurysmal right coronary artery in both of these views. And on this multiplanar maximum intensity projection, you can see this very aneurysmal right coronary artery in this child. So remember the Coumadin ridge and remember the eustachian valve over here. This is now an MRI. We have a quasi sagittal view. This is our descending aorta. This is going to be our IVC over here. This is going to be our right atrium. And this is going to be our left atrium. Interatrial septum over here. And right as the IVC is joining the right atrium, you have this prominent structure right here. This is your eustachian valve. And its embryological role is, as oxygenated blood is coming from the umbilical vein through the ductus venosus into the IVC, and then this oxygenated blood from the IVC hits the valve and gets diverted and crosses over into the left atrium. This is, of course, in utero, but just so you know, the embryological purpose of this structure is to direct blood flow over to the left atrium. So on our short axis MRI, I'm going to slow this down. This is the basal cine image. This is now at the level of the valves. You can see mitral valve, aortic valve, pulmonic valve, and we're actually just above the tricuspid valve. So the tricuspid valve is in this region. So mitral, tricuspid, aortic, pulmonic valves. And we keep inching upward toward the atria. Now we're definitely at the level of the atria. We have the left atrium, and right here we have the eustachian valve. Can be very scary, very prominent. You can see, like on this view, there's like a mobile mass right here, jumping up and down, right next to the IVC, joining the right atrium. Another thing that can happen with patients who have indwelling catheters for a long time, that as the catheter is irritating this portion, clot can form. And then it can get calcified and it can look really scary. So sometimes we get referrals from our clinicians for a right atrial mass that's actually calcified, and it's exactly at the location of the eustachian valve. So as the central line is dangling there and maybe a fibrin sheath develops on it, and it's irritating the wall of the right atrium and the eustachian valve, this is a very common location for patients forming chronic organized clots that can later even calcify. So very important not to mistake that for neoplasm. Here's another pseudo mass, which can look really mass-like when patients have kind of a pushed up diaphragm and a little bit prominent aortic root. Then the aortic root, specifically the non-coronary sinus of Valsalva, can protrude into our dedicated cardiac views, which I've seen happen even on echo, and can actually give this appearance that there's a septal mass, an atrial septal mass. And sometimes these patients come to us with a referral of possible myxoma or indeterminate interatrial septal mass, poorly visualized, especially in bigger patients. Transthoracic echocardiography, it's sometimes very hard to visualize the interatrial septum properly. Also, this portion is smack dab in behind the sternum, so sometimes the acoustic windows can be fairly challenging. But not to fret, this can be easily imaged with additional series and by adjusting the cardiac planes. Typically, if you adjust your 4-chamber a little bit more caudally, you pull up a 2-chamber view for reference and tilt the imaging plane away from the central portion of the heart a little bit more toward the inferior caudal portions of the left atrium and left ventricle, you can get rid of this pseudomass in the middle of the interatrial septum. So this is not an actual mass. This is just the aortic root protruding into our imaging view. This patient had a right atrial mass, quote unquote, and you can see this very elevated right hemidiaphragm, and you can see that it's pushing on the right atrium. And on echo, it looked like this right atrium had a mass that was contiguous with liver. And you can even do real-time imaging and thereby make sure you can see as the patient is breathing that this protrusion of the liver, this eventration of the diaphragm, is actually moving alongside the right atrium. So there's no tethering here. There's no actual mass between the right atrium and the liver here. It's just that the patient's right hemidiaphragm is elevated and is pushing on the right atrium. So again, not an actual mass. This patient actually had endocarditis. You can see a right heart two-chamber view. You can see the right ventricle, which is kind of more triangular, tricuspid valve, and the right atrium here. And you can see that it's all sitting on the liver, and you can see a little bit of the IVC here. Now, this is actually a MINIP. It's a thin MINIP, a minimum intensity projection, which sometimes we use to accentuate low density structures like chordate tendinae, valve leaflets, and papillary muscles. You can see as the right ventricle contracts in systole, and best seen at end systole, that there's a bulge, prolapse of the tricuspid valve leaflet with a mass-like structure. So remember that there are papillary muscles also in the right ventricle, typically 3, and they anchor and keep the tricuspid valve leaflets from prolapsing. In this patient, due to endocarditis, the patient actually developed rupture of the papillary muscle. So this is not just a vegetation, but is actually, if I look at it in diastole, this is the perfect location of one of the papillary muscles in the right ventricle. So the mass that we're seeing that looks like, oh, could this be a valvular mass or could this be a vegetation? This is actually a ruptured papillary muscle with acute prolapse and tricuspid valve regurgitation. Remaining with the theme of endocarditis, in another patient here, what we can see, they had a paravalvular abscess next to the aortic valve. So here is our aortic valve here. It's very irregular. And we have this sinus of Valsalva aneurysm, associated with which is this kind of fistulous tract and this big vegetation that actually also communicated with the left atrium. So if it's confusing, this is our aorta, this is our left ventricle, and this is our left atrium. It's a quasi 3-chamber view. So this patient developed bad aortic valve endocarditis with a perivalvular abscess and the fistula rupturing of this perivalvular now aneurysm into the left atrium. On the other view, I'm going to slow this down. For us, we're coming from a 3-chamber view right here, aortic valve over here, mitral valve over here. This is a CT. You can see how destroyed this aortic valve is with all these big vegetations, even calcification. The sinus of Valsalva aneurysm over here with the adherent vegetation. And you can see that fistulous tract between the aortic root and the left atrium over here. Obviously, this is a big problem. You can even have adherent clots and additional vegetations. This is going to be a big problem for potential stroke and embolization. So as I'm turning the patient into the en-face view of this aortic valve, you can actually also see that this is a bicuspid valve, a functionally bicuspid valve, where the left and right coronary sinuses are a little bit hypoplastic, and the left and right coronary cusps of the aortic valve are fused. You can also see this diffuse valve leaflet thickening. and the asymmetric nature of all these sinuses of Valsalva. So this patient had bad endocarditis with intracardiac vegetations. One more example of a mass that's not really a growth, but it's important to keep it on our differential, especially if we have institutions where coronary artery bypass grafts are performed on patients. So here, I'm going to try to point out the different findings. Oops, I'm sorry. So over here, we have a little bit of pericardial calcification as well. But what we see is the right atrium, the SVC, the right ventricle over here. The LAD is going to be over here, kind of on the left side. We see a little bit of the ascending aorta and this bypass graft going to the right coronary territory. There are additional bypass grafts going leftward. And we see that the more inferior one is kind of going around this big mass, but the more superior is actually going into this round mass. We also have a fourth graft going around the mass down here to the LAD. This is going to be the lemma, the left internal mammary artery, with its clips as the surgeons clipped the intercostal branches. So now we're turning the patient a little bit. More looking from the left side, we have the right ventricle over here that's anteriorly with this pericardial calcification. You see the LAD between the two ventricles. You can see a little bit of the lemma graft. Some of it is cut off here, but you can see this round mass that has a mass effect not only on these grafts, but if you cut into the heart and look at this view, you can see that this is the left ventricle, this is the left ventricle outflow tract, a little bit of the aortic valve and the aortic root ascending aorta. So up here, this is actually our main pulmonary artery. So this giant graft aneurysm was actually nearly completely occluding and compressing the main pulmonary artery. You can also see that this graft probably had a lot of history because you can actually see a little bit of a stent over here as the cardiologist tried to probably fix this aneurysmal stent or aneurysmal graft. This is a different view of the main pulmonary artery and this severe compression by this bypass graft aneurysm. And over here, you can see a 3D reformation of the main pulmonary artery where it's completely flattened and compressed. And this poor right ventricle is now developing hypertrophy because it has such a high resistance to work against. And this is just a dedicated multiplanar view of the same thing. Now you have a right ventricle that's hypertrophied, a septum that's flat, an interventricular septum that's flat, and an RVOT and main pulmonary artery that are both compressed and narrowed by this giant aneurysm. And this one is just an axial view up top where you can actually see the stent within the bypass graft aneurysm. On the next picture, I'm just going to play this movie so you can kind of get an overview understanding of what really is happening here. So these bypass graft aneurysms typically develop in venous grafts, saphenous venous grafts, more commonly than in arterial grafts, but they're not exclusive to venous grafts, but they can be really, really scary. It can look like mediastinal lymphadenopathy, especially if you're looking at a non-contrast scan. They can look like enhancing masses all over the heart. They can be multiple. So they're just a very important differential to remember if somebody has had coronary artery bypass surgery. Let's talk about pericardial hematoma real briefly. In one of our recent sessions, we reviewed a case in detail. They can look very, very scary, very, very well formed within the pericardium with significant mass effect on the heart, depending on where in the pericardium they are. Various chambers can be compromised and compressed. They can have this very heterogeneous look on T2 weighted imaging. This is a HASTE black blood image. This is a more dedicated, properly T2 weighted image here. Very heterogeneous, almost looks like a multicystic mass. There's a left-sided diffusion, which would make us think that since this is on the left side, maybe there's some compromise of pulmonary venous drainage on that left side. This is our SSFP look. Remember that SSFPs are T2 over T1 weighted, so it kind of does give us that T2 weighted appearance, but we have to remember it's not a true T2 weighted image. And over here, we can see the late gadolinium enhancement image, where there is some heterogeneity within the pericardial hematoma. You can see this marked compression of, to some extent, both ventricles, but primarily the left ventricle is the one that's being compressed. And the pre-contrast vibe appearance looks already to have intrinsic T1 signal. And if I turn on to the post-contrast appearance, that you see that there's not significant enhancement, at least not in the early arterial or early enhancement phases. It's also important to remember that on our magnitude delayed enhancement image here versus the phase sensitive inversion recovery, the appearance of the hematoma will look vastly different. But very important to remember that these delayed enhancement images are not for characterizing masses outside the heart or even inside the heart. They're really purposed to evaluate the myocardium. So when we're evaluating masses in or around the heart, we should use more the dedicated T2 weighted, dedicated T1 weighted images and decide the signal characteristics based on that and not based on late gadolinium enhancement images, because we can be misled. But this is a very typical appearance of an old organized pericardial hematoma that could look very, very scary and very, very ominous, but in fact, it's sort of a benign finding. Again, very typical after trauma or after cardiac surgery. So now we've arrived at actual cardiac masses, but we're still not talking about growths in the heart. Nothing is growing necessarily, but a clot is formed in one of the chambers, and it's always there's going to be a cause for it. So I would say if you're seeing a cardiac mass and you've ruled out all the non-mass structures, all the normal structures, the next thing, and you're thinking a clot, don't just look for clots, look for the reasons that could lead to clot formation. What are these reasons? Decreased wall motion, whether it's global or regional, can lead to stasis and clot formation. In myocardial infarction, both in the acute phase and then later on in the subacute and chronic phases, you can have formation of clots in the heart, typically the left ventricle. And but you can also see it in non-ischemic cardiomyopathy, when there's global hypokinesis of the heart and when there is stasis in the atria, for example. The patient does not have to be in atrial fibrillation to form clots in the atria. You can have patients with non-compaction cardiomyopathy where the heart is not only dilated and in areas thinned, but also there's hypertrabeculation. So amongst the trabeculae, it's relatively common that those patients form clots, and then those can cause embolic events. In patients with mitral stenosis, it's very common to form a left atrial thrombus as well. So stasis is going to be one of the main reasons. The next big reason for forming a clot in the heart is going to be some sort of a foreign body. That could be a pacemaker lead, a central line, some assist devices, or catheter-based closure devices, artificial valves, inferior vena cava filter that got loose and ended up in the right atrium. I'm going to actually show you an example of that. Sometimes even sternal wires, if they're inadvertently including a little bit of one of the atria, typically the right atrium, if that happens. And a foreign body can be an actual mass as well. So here in sort of big parentheses, I will include neoplasms, intracardiac neoplasms as well, because those abnormal tissues can cause a thrombogenic environment, and then bland thrombus, just normal clotted blood, can form on top of the mass. So that can lead to a confusion sometimes, where we are trying to decide, is this a tumor? Is this a tumor thrombus? Or is this actual thrombus that's just clotted blood that could go away with anticoagulation? So it's always important to remember, and I will show you some examples for that, that whenever there is abnormal tissue growing in the heart, it gives the heart a propensity for forming bland thrombus on top of it as well. And of course, any of the inflammatory states of the heart and any systemically inflammatory states and hypercoagulability can lead to clot formation in the heart, or can assist the formation of clots in the heart if patients have cancers or patients have endocarditis or myocarditis. In those patients, we always have to be vigilant and look for clots. Typically, we're looking on the high TI, early enhancement images. And it's very important to look in all chambers. Most important to look in the left atrial appendage, of course, because those can hide and can lead to stroke and other embolic events throughout the body. So let's look at a couple examples. Here we have a patient with mitral stenosis, a massively dilated left atrium with a big left atrial mass. Notice that on this SSFP sequence, the clot itself is sort of heterogeneous. And that's actually just a good depiction of the fact that clots can have this very variable appearance on the various T2 weighted, T1 weighted pre and post contrast images, because as the clot ages and different parts get organized, they can have very different signal characteristics. Over here, we can see a black blood image in the middle, where we can have a little bit of T2 weighted signal in it, although this is a haste image, so it's not a properly T2 weighted image. This is a delayed enhancement image, which is a magnitude image. Again, very, very important not to try to read too much into the signal characteristics of the clot itself. You can see how it's heterogeneous, and it almost looks like there is delayed enhancement in the middle of the clot. This is not delayed enhancement. This is just a function of the inversion recovery technique and the fact that this sequence is optimized to look at the myocardium. So we don't want to over-analyze these clots. This is not a sign of enhancement in the clot itself. Down in the bottom, you can see a dedicated T2 weighted image where the clot appears very, very bright. And here you can see the phase-sensitive inversion recovery version of the delayed enhancement image, where it's more truthfully showing you the fact that this clot is actually not enhancing. So very important to keep that in mind. Late gadolinium enhancement images are not for tissue characterization. And on this short axis image, you can just see the mitral valve orifice. Obviously, if the cardiologists were unable to quantify or characterize the severity of the mitral valve stenosis, you can always measure the mitral valve orifice at the time point of its greatest opening, but that can be tricky because the mitral valve filling can be biphasic, so keep that in mind as well. Or you can measure the peak velocity of the mitral valve and through the mitral valve with phase contrast velocity mapping as well. The next is atrial fibrillation. Note that with slow flow in the left atrium, left atrial appendage, you can have this appearance, extremely important to get a delayed phase image, roughly about at 1 minute after contrast injection, because this can fool us every time if we just have the arterial phase images and we see a filling defect in the tip of the left atrial appendage. We have not completely evaluated the patient. Now, remember that slow flow in the left atrial appendage, even in the absence of an actual clot, could be a problem for the patient and makes the patient more likely to form a clot in the future, and could correspond to this spontaneous echo contrast that echocardiographers see in the left atrial appendage sometimes. So it's important to mention whenever we see slow flow in the left atrial appendage, but we always need a delay to decide with certainty whether or not there's an actual clot. The other thing you can do is look at the heart in motion if you happen to acquire motion images, and you might see some swirling or actual blood moving in and out of the left atrial appendage if you are able to review the functional images, but that's less reliable than having delayed images 1 minute after contrast administration. Remember that for the delayed images, you do not need to acquire function. So here is just an axial view. Hansfield unit here is 44 Hansfield units. This is the arterial phase. Notice that the Hansfield units in that area of filling defect actually went up to 111. And then you look at the third image, which is a delayed image, is 133. So this is sort of a trick. If you have a non-con and then a with contrast arterial phase, and the increase in the non-opacified portion of the left atrial appendage is significant, then you can kind of gather that it's probably just slow flow, but you cannot be sure 100% until you get a delay and you have uniform filling of the entire left atrial appendage. So let's move on. So here's just a patient, just as a reminder to make sure that you're looking for clots not only in the left atrial appendage, but also some patients can develop clots in more than one chambers. Obviously, there's a big clot in this left ventricle. There is a big or multiple clots in this left atrial appendage. Over here, this is our delayed images, are the last ones that I'm leaving up. And here we can see the tip of the left ventricle and the tip of the right ventricle over here with multiple clots in the right ventricle as well. So sometimes, unfortunately, some patients will develop multiple clots in multiple chambers. So don't have satisfaction of search. If you found one, you might have to look for others as well. An interesting finding here in this right ventricle on the delayed phase, where you still have very dense contrast outlining these clots, is simply because of the very, very slow flow in the right ventricle. This heart was globally very, very hypokinetic. And that's probably why both the inflow of contrast was slow, but so is the clearance of contrast from that chamber. And sometimes you can see that in chambers where there is very, very sluggish flow and a lot of stasis, that the clearance of contrast will be very, very slow. And if your institution does open heart surgeries, it's important to remember that a lot of the time, the right atrium, the right atrial appendage is used for the venous cannulation, and there's a purse string suture there that is closed after the venous cannula are removed. And very often in the early postoperative weeks, you can find a right atrial appendage thrombus, and that's almost an expected finding. We don't need to make a big deal out of it, but it is a real finding, so don't be too surprised. Even if the patient is doing just fine after surgery, they're not in atrial fibrillation, it could just be sort of expected postoperative finding. We mentioned foreign bodies as reasons for forming clots in the heart. Artificial valves, like you can see in this tricuspid bileaflet artificial valve, especially if the patient runs out of anticoagulation or something is wrong with the medication, or maybe sometimes changes in diet can affect the efficacy of anticoagulation. You can actually see that this valve, the valve leaflets are not moving properly, and there's a small filling defect in between the two leaflets, and that actually is a clot. And as long as the patient is hemodynamically stable, if they're anticoagulated, those clots can resolve and the valve leaflets can regain their function. But the differential, especially if the filling defect is around the edges of the valve, could include infective endocarditis of the artificial valve as well. On this other image, you can see an IVC, an inferior vena cava filter that has embolized into the right ventricle. And we also mentioned central lines that are frequent causes of clots. And here's just a rare case of a clot forming in the right atrium right behind the sternal wire, where the sternal wire actually pinched a little bit of that right atrium, and an adherent thrombus, a mobile thrombus, was formed within the right atrium right behind that sternum. And I'm just showing you different views of this over here on the various sequences. This is the post-contrast overview of the chest. Remember that this is not a cardiac gated study, so that's why the mass itself is blurred since it's moving. But you can see it very nicely with the artifacts of these sternal wires. This patient also happened to have some degree of pectus excavatum. You can see how the AP diameter of the chest is significantly reduced. We also mentioned systemic inflammatory processes. One of those is Loeffler's endocarditis, when the patients are hypereosinophilic and an endomyocarditis happens. We reviewed this a couple sessions ago, where there's this diffuse subendocardial lead gadolinium enhancement, not just in the left ventricle, but very often also in the right ventricle. And sometimes you can see actually enhancement in the atria or even in the valves in Loeffler's endocarditis. And on the pre-contrast T1 weighted image, you might see hyperintensity, as you would expect from a clot. And then if we give contrast, we can see that there's this non-enhancing big mass in the left ventricular apex. Very characteristic view for Loeffler's endocarditis here. A lot of these patients also have clots in the tip of the right ventricle. So at this point, we're going to stop for today to keep it in a digestible portions. So I'm going to stop the recording, but I'm going to open it up for questions specifically with regard to cardiac masses. But if you have anything else, I'd be happy to entertain those. Thanks for being here today.